Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sack. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and to review core topics. Today's edition of our Conversations from the World of Allergy podcast series will focus on the topic of severe asthma. There are more and more novel treatments for severe asthma than ever before, and we'll discuss the power of biologics in these patients. There are also phenotypes of asthma without good treatment, and we will discuss these as well. We are pleased to welcome Dr. Juan Carlos Cardet. Dr. Cardet is an associate professor in the Department of Internal Medicine within the Division of Allergy and Immunology at the University of South Florida College of Medicine. His research focuses on understanding the pathophysiology of severe asthma with the aim of identifying novel therapies. Well, thank you for joining us today. I'd like to start by getting to know you a little better. Can you just tell me a little bit about yourself, including something you like to do outside of medicine?
Thank you so much for having me, Rebecca. About myself, I was born in San Juan, Puerto Rico. I did my fellowship training at the Brigham while you were at MGH doing your training. I'm now at the University of South Florida. I've been here for the past almost 8 years. Time flies. And I have things that I like to do outside of medicine. I think the beaches here are phenomenal, and so are the springs. I think we were talking about that. A little known fact that in Central Florida, some of the most beautiful springs. You can go kayaking and paddleboarding, something I like to do with my kids.
Yeah. Which I learned that springs are like beautiful little lakes that are clear and have beautiful temperature water.
All year round, 72 degrees, transparent water.
That is not what we have here in Boston, so definitely something to take advantage of.
Especially
and what
January,
made you
February.
choose allergy, especially in January and February? What made you choose allergy immunology as a field?
I think coming from Puerto Rico, where asthma is such a big issue, prevalence is higher, morbidity is higher. I chose a field, allergy and immunology, where I can do something about it and take care of these patients, but also allergy over pulmonary, more the outpatient type of contact that you see with patients and establishing like long-term relationships with them, but also not only asthma, but being able to evaluate and treat a whole host of diseases across many different systems, and being able to do something about it beyond what you can do in primary care.
Absolutely. So today we're going to focus on severe asthma, and I want to start just by the definition of asthma. So we're all of severe asthma. So we're all on the same page. How would you define severe asthma?
I think most of us follow the ERS ATS task force definition from 2014, and that's now in the guidelines. So severe asthma is asthma that requires treatment with high dose inhaled corticosteroids plus a second controller, or that symptoms remain uncontrolled despite such therapy, which might also include oral systemic corticosteroids for maintenance. And I think a subtlety in that definition is that also includes patients who might have contributing comorbidities or who have issues with adherence, which is a major problem in asthma, adherence to the control of therapy or lack of proper technique. Once you start excluding those, then you talk about severe refractory asthma.
How do you think patients define severe asthma? Do you think it's different than we as physicians define it?
Oh, absolutely. I think it's many of us have trouble with the definition, especially patients. I think patients define asthma if it's too bothersome, if it's affecting their quality of life. If I think the most commonly cited by patients outcome that matters to them is asthma exacerbations, just because it's so disruptive of their life. Many people have childcare responsibilities or taking care of somebody at home, or jobs. They have work responsibilities, and anything exacerbations are truly disruptive in that way. So that definition does not necessarily, severe asthma does not necessarily encompass all those aspects. I think work, for example, from Joe Zine that was published last year in Lancet Respiratory. He showed using data from SARP, Severe Asthma Research Program, and then UBioPred, two large cohorts here in the US and also in Europe, that there is this disconnect between burden of disease from asthma and then asthma severity categories defined as severe or non-severe asthma. So I think there's a move both in research and from patients and from clinicians in having a definition that reflects more of that burden and is less dependent on how prescribing patterns, which are highly fluctuate and are highly prescriber dependent.
Sure, absolutely. There's also this overlay. Some patients have higher sense of their asthma, so they can feel even small changes, and some people won't sense it until they kind of fall off a cliff and get into a severe exacerbation. Does that play into it?
Oh, absolutely. I think you're speaking truth right now.
So if you have a patient that comes to you who's new, you haven't met before, who's billed as severe asthma, or that's the sense you get during the history, what are the things that you really want to make sure that you get, the data that you really want to make sure that you get for them?
I think especially for severe asthma, it's important to phenotype them. One is to confirm the diagnosis. You do that with full PFTs, although it's challenging and you still might get issues in diagnosing asthma. But I think it's important to document severity of obstruction, whether or not there is bronchodilator response, and what the DLCO might be. So whether this patient has emphysema. Many patients with asthma also smoke or vape or use cannabis. It's incredibly or paradoxically, sometimes it's even higher, the prevalence of those behaviors compared to people who don't have asthma. So clarifying the diagnosis, it's number one priority. You do that with full PFTs and also history and physical. But also, I think it's important to rule out mimickers of asthma and comorbid conditions that contribute to asthma severity. It's super important. Some of those important comorbid conditions that need to be evaluated and treated include vocal cord dysfunction and other laryngeal disorders, which can mimic asthma or can also, especially in severe asthma, coexist. And also obesity. It's you look at our randomized controlled trials, the mean BMI is in the obesity range, at least in this country. The obesity epidemic mirrors the increases in asthma prevalence that we have seen since compared to the 60s, 70s, right? And the data seem to show that if you control obesity, reduce obesity, then asthma tends to get better. Also GERD, and there seems to be a vicious cycle, a feed-forward mechanism between GERD and asthma. The higher, the greater the asthma, perhaps the greater air trapping and hyperinflation that you can see in the lungs. It seems to feed forward with the GERD, and then the GERD, extra esophageal symptoms of GERD seems to trigger more asthma exacerbation, so on and so forth. And also just assessing mental health issues that's another one that feeds forward with it. Having wheeze and shortness of breath can trigger worse mental health disorders, and then the mental health disorders can also trigger the sensation of breathlessness in asthma. It seems to be interdependent. Obstructive sleep apnea is another one that often happens, especially with the nocturnal symptoms that you can see in asthma. Sometimes hard to tease apart.
And one of the things we know that's so important is the patient's adherence and their inhaler technique. How do you assess that?
I think asking them in two separate things, right? Adherence and then the inhaler technique. I think for the inhaler technique, you have to have them with the inhaler that you prescribe because it varies. The mechanism varies just enough between models, right? Or if it's an HFA versus DPI and how they can use them. So if either for yourself as a clinician or for somebody from your office to establish a proper inhaler technique is super important. But then the adherence issue, I think it doesn't matter what country or what age stratum or race, it doesn't matter. people with asthma tend to not use the amount of therapy that we prescribe as control therapy. 25 to 50% of all the doses are actually taken if you look at pharmacy refill data. And it's a big issue. Lack of adherence is associated with worse morbidity. It's the reasons why people don't use their control therapy are many from different angles. Sometimes it's socioeconomic issues or barriers that proper access to care. But sometimes it's just human nature. Asthma is an episodic disease, and if they don't feel any symptoms, they feel, why am I going to take any medicine for it? So I think a non-judgmental, people don't like to be told what to do, and especially if they're already showing you that they're not doing it. It's I think understanding some of the barriers to why they're not doing is important, but also having a non-judgmental attitude and perhaps asking something, how many puffs do you do per week, as opposed to a leading question like, are you taking your asthma controller every day? Then they'll say yes, because that's the social desirability bias or something. They might think that they want to give you the right answer. I would rather have the honest answer. But I think another one that's important to assess whether patients are taking their inhalers and how they're taking them came up from some of the research we were doing. This is work led by Victoria Forth. She's a PA at Brigham and Women's with Elliot Israel's group. And we had this clinical trial that for the pilot phase, we had to find out what names they were calling their inhalers, because terms like controller or rescue was not tracking with many of the patients. So we were asking them what they call it, and then in subsequent surveys, we would use the same terms. So what we found was that maybe 50%, maybe half of all patients were using what we called non-standard terms, meaning they used a term, a name for their inhaler that most clinicians would not know what it means. And these were in the categories, for example, of color. The red one. The red one might mean something like Symbicort, or it might mean something like ProAir, for example. So very different categories of medication. But also they use terms like specific words like friend or Bob or nighttime savior or something like that. And that was nearly half of all patients that use terms like that. So in Victoria's work, the question that we asked was, does that associate with any outcomes? And what we found was that after adjustment for standard covariates, plus after adjustment for education and medical healthcare literacy, people who use non-standard terms were about 30% higher of experiencing asthma exacerbations, were 50% higher in terms of getting ER visits for asthma or hospitalizations for asthma. And what do you do with this information I'm telling you right now? We're still not sure what to do with it, but it just means it's a risk factor for exacerbations. And if you ask me about adherence to therapy, I also now hold out the inhaler and ask them, what do you call this?
Yeah, one of the things I think that affects both adherence as well as inhaler technique is the fact that insurance changes. And now someone went from an inhaler that was working well for them, they understood, and now their insurance will cover it, and they have to choose a different inhaler. They don't really know how to use that one. It doesn't work as well. And then they also now have 4 inhalers versus 2 that they're not sure what to do with. So I will often have my patients bring in their inhalers, not only to demonstrate their technique, but also to write on them, controller, daily, or rescue, as needed, that just directly on the inhaler, just because so often they don't know which one is for which, and they're just grabbing whichever one they have to try to use it.
I think you hit the nail in the head, and I really like that best practice method you just outlined there, Rebecca. I think insurance coverage is probably among the top reasons why people might adhere to one therapy or lose their adherence to therapy, and what you're doing with your patients and writing on the inhaler itself. I think that's very valuable.
And you mentioned that now we're spending a lot of time phenotyping our patients as we think about kind of their asthma. How do you phenotype your patients? What are the different phenotypes you categorize them into?
So back to the original question that you asked, right? What to do with severe asthma patients? So phenotype them. First, ascertain the diagnosis, and then get an impression about bronchodilator response and degree of severity of their obstruction, and then clarifying the diagnosis versus emphysema, for example. But in addition to that, I think it's very important to get blood eosinophil counts and fractional exhaled nitric oxide, FeNO, right? I think those are very important to establish this type 2 inflammation. I think most of us know about this. It's now been in the literature for quite a bit. It's type 2 inflammation is driven mostly by interleukins 4, 5, and 13. There's others, but those are the canonical ones. And there is why should we do this type 2 inflammation versus non-type 2 asthma, right, which is more like an absence of a definition. It can be either neutrophilic type asthma or paucigranulocytic, that you go looking for signs of inflammation in the airway and you don't find either neutrophilic or eosinophilic, but yet have typical signs and symptoms of asthma, yet no inflammatory subtype. The second one, non-type 2 asthma, is harder to treat, although there are several therapies coming in the pipeline that might be promising for them, remains to be seen. But type 2 asthma, it's important to get blood eosinophils and FeNO because you can get an assessment. One, it's a risk prediction tool. I think Simon Coulard from Quebec has done that's work from him, and Ian Pavord have done the work with the Oracle study. The second iteration of it came out now. It's in Press and Lancet Respiratory. And what I think it's neat about that one is it takes into consideration things like in the history of exacerbations in the past 1 year, but also does this person have comorbidities, and what GINA treatment step are they in? And based on the blood eosinophil counts, low, medium, high, I think they used more than 300 per microliter, and then FeNO 0 to 25, 25 to 50, greater than 50 for FeNO. You get this in this figure, this red, yellow, and green zone, with the people in red, those being at highest risk of asthma exacerbations. And I think that's very helpful for the clinician. It's because often we delay the use of therapies that might really prevent additional exacerbations. And this is something we need to communicate to patients. It's there is harm from both having an additional exacerbation and a more steep decline in their lung function. Every human being, it's part of human nature, right? Our lung functions deteriorate, but for the asthmatic, they deteriorate more rapidly, and especially for the severe asthmatic, and especially after exacerbations. If we can find biomarkers that help us phenotype the patient and then predict that risk, I think that's very valuable. And the other part is our current paradigm is to treat them with systemic corticosteroids, and they come with all sorts of side effects, and trying to minimize those, I think, is very important for the patients. So a bunch of different reasons to phenotype them.
Yeah, we're learning more and more about steroids, not only these short-term side effects, which I think we've known for a long time, but even the cumulative effect of these multiple steroid courses. So even though it doesn't seem like they're getting a lot, even 1 or 2 exacerbations a year is a pretty significant steroid exposure.
Exactly right.
Yeah.
It adds up before you know it.
So you mentioned that we have these new developments for particularly severe non-T2 asthma that are on the horizon. Could you tell us a little bit about what we're looking at in terms of the future of asthma treatment for that group of patients? Because they've traditionally not had much that we can use.
Sure. Yes. Well, I think if you guys are going to be at ATS in San Francisco in a few weeks, we're going to hear the results from the NHLBI PRECISE study. I think that's going to be quite interesting. I think several of the treatment arms that were studied in this biomarker-driven adaptive design clinical trial, which is pretty cool. And many of them target non-type 2 asthma. So it remains to be seen, and I can't say any more about that. It's just that it's exciting. But I think out there, OX40 biologics that target OX40 or OX40 ligand seem very promising and not specifically dedicated, even though it targets type 2, but it targets other types of inflammation as well. I think BTK inhibitors target multiple cell types beyond Th2 cells or ILC2s, and that's also pretty promising. I think the inhaled JAK inhibitors target multiple inflammatory pathways as well, and those are pretty exciting. I think there are other alarmins that are being targeted with biologics, and those might also be effective in non-type 2 asthma, IL-33. But I think in terms of the development pipeline, because of what we were talking about before, the patients not really wanting to take their controller therapy, the development of biologics that are dosed twice yearly, I think that's also very promising.
There was definitely the study in the New England Journal recently about a IL-5 inhibitor that could be given twice a year that had good efficacy, and hard to imagine a patient not wanting a medicine they can take so infrequently if it's effective and low side effect profile.
Exactly right. I think one very cool development from recent, I think within the past year, was the benralizumab administered at the ER. That was the ABRA study, which showed that relative in patients with severe asthma and COPD, at the time of the exacerbation, they were randomized to one of three arms. One of them was standard of care with systemic corticosteroids plus nebulized salbutamol. This was in the UK. And the other arms were standard of care plus one shot of benralizumab or nebulized salbutamol, no steroids, and benralizumab. And both benralizumab arms, with and without corticosteroids, compared to standard of care alone, reduced asthma exacerbations at 3 months by 75% or so. No difference between the two arms, putting the possibility of treating asthma exacerbations without corticosteroids on the map. And also addressing the whole issue that we have with the fragmentation of care that we have in this country, which is, I think, Tara Carr's study that was published in JACI in Practice, November 2024, late last year, showing that most people who have an exacerbation, a year later, they haven't seen a specialist. It's I think there's work from others, Hector Ortega as well, that the most uncontrolled asthma in the country is not cared by us or the pulmonologists. They're cared for by PCPs or even not PCPs. They just use the urgent care or ER to manage their asthma. So interventions, that can treat with all these advances that we're talking about, the understanding of the biology of asthma and actually putting it to use in the people who need it the most is an interesting strategy, potentially fruitful.
Absolutely. And so for those patients who have more of the T2 high type of asthma, and now we have a number of biologics available, a number of different therapies, how should we as clinicians think about moving between them or choosing one to start with?
I think we have 6 clinically available biologics, and their effectiveness is more or less the same. There's just enough variation in how the clinical trials were designed that make comparisons between them hard. And we know that they mostly treat best mostly the same population with and high eosinophil count seems to be a good treatment response biomarker for them. And you need to, as a clinician, you need to consider things like patient preference and what medication is best covered, and it's not going to cost an eye and a hand to your specific patient. But having said that, I think most of us like to have an approach where it's kill multiple birds with one stone, address multiple comorbidities if you can with a single product. So, for example, if your patient has atopic dermatitis and also has severe asthma, then many people choose dupilumab because it's indicated for both, right? And if somebody has bad food allergies and also has asthma, then many people would choose omalizumab because that's the only one that's currently indicated for food allergies as well as asthma. If your patient has a very high eosinophil counts in the hypereosinophilic syndrome range or EGPA range, then an anti-IL-5 targeting biologic that makes a lot of sense. If your patient has nasal polyps, there's multiple products now, but recent data for tezepelumab looked very promising for the treatment of polyps and also for asthma. And if biomarkers are low, the only one that seems to be best suited for that seems to be tezepelumab so far. So that's a very simplified algorithm, and there's much more nuance. For example, interval of dosing administration. If they want less frequent dosing, benralizumab, you can push it to every 8 weeks. But now that's, with the depemokimab coming out, that's every twice yearly. That's, patients are going to have more options in that domain. And there's a twice yearly anti-TSLP that's also being investigated now. There's a lot of nuance about this.
So what about the idea of remission? So we start our patient on these biologics, they get better, they're having, amazing success with them. How do we think about remission in these patients? Is there a way that we can get them off of these medications, or is this really something that this is a long-term plan?
I think if you ask 100 allergists for a definition of remission, you're going to get 100 different answers. And I think usually definitions have some threshold for asthma control that they want to see in remission, and some threshold in lack of further deterioration in lung function. What's usually consistent, universally consistent, is no steroids, no systemic corticosteroids, no exacerbations in the next year. If you keep adding additional eligibility criteria into that definition, then it's a much smaller sliver of the population that can actually achieve remission. But I think what we have so far is on biologic remission. I haven't seen yet a biologic that convincingly and universally and consistently, you give it for a little bit, for a while, and then asthma goes away forever. I think that's still the holy grail where we want to go to. Treat them for a while and then make the asthma go away.
We're not there yet, but hopefully someday, especially with all these new medicines on the horizon, we'll have something.
Hopefully someday, yes.
I wanted to switch gears and talk a little bit about the mild to moderate asthma group and this idea of using a maintenance and reliever therapy that would involve both a steroid and a bronchodilator. I know that there's different ways to do it. There's kind of the SMART therapy, having a single maintenance and reliever therapy, and there's combinations. Who are the patients that you recommend this for?
I think everybody, except the mildest of the mild asthma, perhaps the exercise-induced bronchoconstriction patient, in which you can get away with using prophylaxis albuterol. Maybe you can still get away with those, but for the rest, even in mild asthma, some sort of as-needed inhaled corticosteroid supplementation strategy. There's enough data now to support one of the existing strategies. How to choose between them, I think that's hard. But I'll say this, even though the oldest strategy was, like you said, SMART, right? Single maintenance and reliever therapy with some inhaled corticosteroid combined with formoterol, which is as we know, long acting, but quick onset, right? That's the strategy that has the most supportive data from throughout the planet, right? And it's made it into the guidelines. It's the first one that made it into the GINA report. Except that Symbicort, for example, is not FDA approved for rescue in this country, which makes it implementation and dissemination into our healthcare system, much harder. So, for example, if you prescribe Symbicort, you cannot prescribe it for rescue. You need to wink at your patient and tell them, use it for maintenance, or just straight, depending on the severity. If mild enough, you can use it only for rescue, but you need to wink at your patient, and then don't do as the instructions say, just do what I'm telling you to do right now. Because otherwise the pharmacy will not dispense. And if they use up all the controller doses plus the rescue doses, they run out of the next refill before they're due. So they're left vulnerable without any controller therapy inhaler before they have access to the next one, which is a problem. Which gets us to the other strategies. Both are ICS combined with albuterol. One of them is Air Supra, which is just like that. It's budesonide combined with albuterol, and that can be matched to any controller therapy. The problem with that one is there's many people out there who use nebulizer machines, especially use them when the asthma symptoms are bad and maybe a prelude to an escalation of symptoms and exacerbation. That's when they use their nebulizer machine. And using either Symbicort or Air Supra along with a nebulizer machine, that's difficult and not really studied, right? So in that circumstance, there's Pardix, patient-activated, reliever-triggered inhaled corticosteroid, which we published a number of years ago now, which is definitely adaptable to any control therapy regimen combination, and including those who use nebulizer machines.
Yeah, some people do love their nebulizer machine. So finding a way to adapt their regimen to include that is very important.
Yes, it's very hard to get somebody off their nebulizer machine. There's many reasons for that. Yeah.
So do you tend to, in these patients, then just come up with a plan that's kind of patient-centered? What do you use during an exacerbation, and then figure out what steroid you can add on, or use after the nebulizer versus a combination therapy? Is that how you approach it, just with each individualized patient?
Yes, I do. I meet people where they are. It's like I can bark at people all I want, but are they actually going to do as I tell them? In most instances, they're no, especially if they already told me that they're not going to do as I'm telling them. So I would rather, give them something that I know is going to help them than something that I know could help them, but they won't take it.
Yeah.
So,
or their insurance won't cover, so they can't get it filled anyways. So
great point. Exactly. That's exactly right.
No, I think that's perfect. I think really meeting patients where they are and having this combination therapy. So if you had just one or two take homes that you want people to take away from this, what would you say?
We've said so many things already. History and physical remain supreme. Consider alternative diagnoses. Phenotype your patients. Do it often. I think it adds value. Helps you predict what's going to happen, and opens up treatment options for your patients, and meet people where they are.
I love it. Yeah. Thank you so much for taking the time to tell us about severe asthma today and how we can meet our patients where they are to get them the best treatment.
Great to be here. Thank you for having me, Rebecca.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at quadai.org. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Google Podcasts, or Spotify so you can receive new episodes in the future. Thank you again for listening.